All right. Chapter 20. So this is pediatric variations in those nursing interventions. So these are the objectives for this chapter. I know they look a little intimidating. They're longer than some of the other chapters have been, but these are things that you should be familiar with from other classes. Again, like fluid balance, administering meds, but we're just going to talk about some of those differences with our peds patients. So informed consent with our peds patients. What is the age of majority and competence? What do we say that patients can give their own consent? What age?
Is it 18?
Yep, so it's 18 in the United States. Make sure that, if you're practicing in another country, there's differences, but 18 in the US. And there are exceptions to that. So some of the exceptions that we have with consent is one is in case of an emergency. So that would be something that we typically define as something that is life-threatening or loss of limb. So like a car accident, let's say they had like a rollover and they had an arm that was crushed and that limb could die, needs treatment, but maybe mom was also in the car accident and mom needs to be treated and she's not able to give consent at the time. Those are things that we can give treatment for. Think about some other examples that may fall into that category. Let's say you're a school nurse at the school and a child has an asthma attack while they're in PE. Would that be something that you could treat without consent?
Yes, because isn't that technically like life-threatening?
Yeah, asthma is a life-threatening disorder, right? So an asthma attack could be something that we could treat without parents' consent. Now, we would do our due diligence, right, and try to reach the parents first. But in the case of emergency, treatment needs to be given. We're going to give treatment if it's something that's going to risk their life or limb. And we have to document that clearly. It has to be documented by the physician on the chart of why we went ahead with treatment without parents' consent or parents' presence. We do want them present as much as possible, but there are cases where that's not always the case. Other things that can fall into this category would be emancipated minors, which a lot of times we see teens that are experiencing homelessness that maybe have been kicked out of their household. They can go through the court systems and can show that they're independently supporting themselves, can get legal documentation saying that they're an emancipated minor. Sometimes that's usually like closer to that 17, 18-year-old age range. We also look at pregnancy as an independent event. So if the teenage mother is pregnant, she can make healthcare decisions for herself and her child at that point as well. So that's kind of outside of that normal consent range we look at. One other thing that kind of falls into that is if parents aren't present, we can get phone consent. So that's something that we can do over the phone if we can reach parents by phone. We can also treat if we have legal documentation saying that somebody else can seek consent in the parent's absence. So I tell parents, especially if they're going on vacation and they've got grandma or somebody else watching their child while they're gone, that they should have documentation that shows that that person that's watching them can seek consent in their absence. And it can literally just be a notified form, a notarized form that says, I give permission for so-and-so to seek treatment for my child, name the child, in my absence, and it's signed and notarized. That can also serve as legal documentation for us. And I've had cases, like I had a kid one time who had a laceration on the forehead that needed stitches. And mom and dad were in Jamaica scuba diving and we couldn't reach them because they were out scuba diving for the day. So grandma brought the kid in for treatment and we had to turn her away because it wasn't something that would risk life or limb. It definitely needed stitches, but we couldn't treat without that consent. We were able to get it later in the evening once parents got back from the boat and grandma reached them. But if it had been the next day, at that point, we can't do stitches. So it was something that if she'd had that note, we could have given treatment for her. There are also a couple other exceptions in terms of disorders and treatment issues. This is Colorado specific, so make sure that you're looking at every state. And just specifically with things like abortions, that is significantly different across the country depending on the state right now. I know have seen the news on how that is impacting and changing across the country right now. But right now in the state of Colorado, it is possible for adolescents to seek abortions without parental consent. There is a waiting window, but they do not have to have parental consent. STI treatment also in the state of Colorado is any age without parental consent. So if they come into the ER, the doctor's office, we can treat them and test them without parents' consent. Birth control is also another one in the state of Colorado that's free up until 24 years of age, and we do not need parental consent for that. And then mental health and drug dependency in the state of Colorado is 15 and older without parental consent to seek treatment for. The parents also, if they are legal guardians, also have the right to request patients' medical records. So there are sometimes things like billing things. If they do come in and seek STI treatment, it's going to be on the medical record. So if parents request that, it is listed on that medical record. Things like mental health disorders, if they're 15 and older, those are sealed medical records. So parents would not be able to see those kinds of things, but other stuff would pop up. So we always kind of talk about that when we have an adolescent that comes in for treatment, of kind of what that looks like. If we charge your insurance, your parents are going to see this. So you should probably talk to your parents about it, kind of thing. But we are going to give that information freely to the parents. All right, preparing kids for procedures. This is something that we've talked about at the beginning of the quarter. Remember, we talked about atraumatic care. We talked about reducing that anxiety, getting the child to cooperate as best as possible, and support their coping mechanisms depending on the age range. So think about age-specific guidelines for preparing for procedures, but that developmental level is also really important to think about, because if they're developmentally younger than their stated age, make sure you're addressing that like you would with that younger child. Think about establishing that trust and the support, really incorporating the parents into that process, especially for younger kids. You know, talking to the parents first can help show that trust for the child that maybe is untrusting of a new person like the nurse that's coming in. Parents should be present as much as possible, especially if you're doing procedures. You want the parents at the bedside. And then explaining to the child at that age appropriate level. Just remember that if you're doing preparation for procedures, the terminology, how we use and talk to them is going to be different than for the different age ranges. And we have to give different explanations for parents as well as the child. You know, if I'm giving an IV and a parent doesn't know what the IV is, I have to talk them through what that procedure is going to look like. I'm not going to do it in front of the child that's at the bed. I would pull the parent out in the hallway and say, okay, this is what we're going to do. And then I would go in and talk to the child age appropriate wise about that procedure. So just kind of an overview of what that looks like, the things that kind of refreshing back from earlier in the quarter, right? With infants, parents' presence is important. That familiar person, that trust person that they have is important. Sensory touch is really important at this age. Things like soothing methods, like the toot sweet, that sugar water that we talked about that can help with relieving pain. This is the age group that we're going to expect resistance. You're going to have to hold them down to do a procedure. You're not going to get an infant to hold still for you. They do have memories of past events, especially those older infants. So they're going to remember things like painful events, like shocks. So they may be fearful of us, especially as we, have to do things that they're already familiar with. And then older infants, remember about 6 months and up, will start imitating gestures. That means facial expressions, body language, how you're saying things are also things that they're picking up on. So be cognizant of how you're carrying your body, your facial expressions, and working with them physically. The toddlers, they're going to start being a little bit more vocal. They may say that no word. Remember, that's their favorite word at that age. Really simple directions, like 1 to 2 word directions at this age. Demonstrating on a doll is very helpful, like having them practice on a doll, but won't show them the frightening things like the needle, anything that could be frightening. You've got a sight for this age group. Should be right before the procedure, right? They have really short attention spans. You have to do it right before the procedure. So if you're doing something like that IV that we talked about with that atraumatic care, it needs to be, have everything out ready to go before you start telling them what you're doing, because otherwise they just it's forgotten. In this age group, expect temper tantrums, expect resistance. This age group, in most cases with toddlers, you're going to have to restrain to do procedures, especially more invasive procedures. We're not going to hold still for you in most cases. We talked about the Foley last week. You're just gonna have to hold them down in most cases. It is almost impossible to talk a toddler off the ledge once they're like screaming and crying and upset. They just don't have the cognitive and verbal skills to be able to understand what's happening once they're already to that point. So usually we just have to hold them down and get things done. The preschooler, we can now give more information to. We still are going to use very, very simple, short, like 1, 2, 3 word sentences with explanations. This is the age group that they think that things that we're doing to them are a form of punishment. They're very afraid of a lot of like invasive procedures at this age. Slightly longer teaching sessions at this point can be done. You still want to do it as close to the procedure as possible, like right before if possible, but you can do it a little bit in advance with this age group. And the example that I'm going to give is my daughter when she had her tonsillectomy that I talked about, the respiratory chapter. Remember we went in the night before and talked with Child Life and we did the tour. So that's like farthest out that you'd want to do with that age group in terms of teaching. Really emphasize no body parts, other body parts are going to be harmed. Like we're only touching this piece or only doing this part. They think that, that active imagination, that magical thinking, they think that all their insides are going to leak out. So things like Band-Aids make everything better at that age. The school age group. Now this is when we can start using scientific and medical terms. We're still using basic explanations, but we can start giving them more information. I tell them, what lung sounds I'm listening to. I talk to them about their body parts and using proper medical terminology. Usually supporting that with like, it's kind of like this, like that example with the endotracheal tube. The question from exam 2 is, I would say endotracheal tube, and I would say, what is this? It's a tube that we use to help you breathe. But I'm not going to talk in like more gruesome medical details in this age group. Give them choices still, but expecting cooperation in this age group. You usually are not going to have to hold down a school age child. They should cooperate. Once you've given them the instructions, they should cooperate with you. They can tolerate pretty long teaching sessions at this point. Remember, they are already sitting in school. For longer sessions, so they can tolerate long teaching sessions. You can do things a day or 2 in advance at this age group and they can remember them by this point. Active participation also helps support things like that developmental stage, that industry stage of development. So giving them things to do, and it can be little things like, can you hold this roll of tape for me or pull off a piece of tape for me? So that just active participation with simple tasks helps them feel engaged with their care. This is also the age group that I talked about, that they're really like start to be more body conscious in terms of like privacy. So they don't like to be naked or exposed in front of other people. So they may not want the parents at the bedside while you're doing something invasive, but you want to make sure that you give that choice and then you talk about that option before you have the parent maybe step out. And then the adolescent age group, think about it more just like your adults. They are cognitively not an adult yet, but you want to talk about rewards, risks, and benefit when it comes to procedures and care. You want them participating in their care, even if they can't legally make the decision. You want them as part of that conversation about performing the cares and what you're doing with procedures, especially when it comes to things like end-of-life decision making in this age group, or significant medical issues. We want them as part of that care team. The age group, remember, peers are a really big part of how they're developing. So getting them involved in things like peer support groups is really helpful with medical information. And that last little note at the bottom there, that regression with new authority figures. Adolescents really struggle with that like concept of independence and trying to push that independence, that they're like developing their own sense of self. So they really have trouble with adults telling them what to do, and that comes a lot from like medical things that we have to do, restrictions that come from medical procedures. The oncology patient that is in the hospital for weeks on end, and it's like, you have to stay in your room, you have to wear a face mask, you have to do this and that, like you have to do this, is really hard in that developmental stage when they're really trying to figure out who they are and expressing that independence. So we sometimes see regression in any age group, but even more so with like the adolescents, with more like us telling them what to do kind of things in the healthcare setting. All right, so think about that. Think about the preparing your patient for a procedure, you know, show them what you're doing, let them touch and feel and see, whether that is with a teaching doll like the picture here shows, or it's a tablet with some videos or a picture of the CAT scan machine or the radiology machine before we go in to help reduce that stress and anxiety and improve their participation. Kids really like pretending to do medical things, especially that like preschool school age range. They really like to play as doctors or nurses. And then think about performing the procedure itself. Remember that atraumatic care that we talked about, that why, who, what, and how. Other things we talked about was using that treatment room as best as possible, right? If you're using their room that they're spending all their time in, that is a scary room for them. So think about doing it in a different place that they're not going to be sleeping in for several days. Go in expecting success. It can be hard as a new nurse to go in and start an IV on a pediatric patient for the first time. Even if you haven't done one on an adult, it can be hard. What if a parent that's at the bedside is like, have you done this before? What are you gonna say? What do you say if a parent says that to you? Because they do all the time. They'll ask, have you done this IV before? Have you done this before?
I'll just lie and say yes. So
Yeah,
at least
like,
as we get that confidence.
yeah, the confidence. Yep. So don't lie, but you've done it before. Even if it's on the sim dummy in the sim lab, you've done it before. Saying yes is not a lie, right? But if they are specific and they're like, have you started an IV on an infant before? I haven't. Don't lie to them. But if they just ask, like, have you done this before? Yeah, I've done this before. Make it till you make it, right? Go in with that confidence of like, I've got this. I know the process of how to do this IV. Even if it's just an adult. And the process of putting an IV in is the same for a peds patient to an adult. Like all the supplies, it's just things are much smaller, not as cooperative, and it can be much harder to hit those smaller veins. So go in with that, like, all right, I got this. I'm gonna get this. And if you don't, you don't. It takes practice. But once you get good at it, it's definitely a skill that like doesn't go away. It's like riding a bike; it doesn't go away. Go in expecting that success. Have all your supplies ready. You know, especially with younger kids, if you're having to hold down a toddler to do an IV on them, make sure that you have all of your stuff like out on your tray table, ready to go. You've got an extra like catheter ready to go, just in case you need a backup. General rule of thumb with things like an IV, if you've tried twice, it's somebody else's turn, right? And we're not always successful. Even as an experienced ER nurse, I have days where I'm like, not my day, I can't get it, somebody else's turn to try. Also, you'll sometimes get parents that are like, oh, I want the doctor to do it. And I'm like, no, you don't want the doctor to do it. The doctor does not start IVs. You want the experienced peds nurse doing it. But yeah, sometimes you'll get parents that'll say things like that. Remember, minimize people present. You want that support person, but just the people that need to be there. Let your patient express their feelings, whether that's sometimes verbally, sometimes it's physically. If I only have to hold down the arm, I'll let them kind of move and wiggle the rest of their body so they're not feeling as restrained. And then just general preparing the family for different procedures. Home care, remember, starts as soon as possible. So if we're thinking about the discharge process, thinking about that prep, you know, from start to finish of what that looks like and helping them prepare for procedures or treatment. And then also who else is involved in terms of things like long-term care. If we're doing, well, let's say an NG tube that this kid's going to go home with, there's divorced parents that the child spends half time with, both parents, you have to give instructions to both parents and make sure that that second parent has the knowledge and the base to be able to do it. Sometimes you can trust the parent that's there to say, yeah, I can give the information to the other parent. Sometimes you can't, and sometimes you have to call the other parent and say, okay, I'm going to run you through the process of how to do this. Here's our information if you need something else. You know, also think about the process of like other people that may be watching the child. You know, mom or dad work during the week and grandma watches the child Monday through Friday. So grandma's going to need this information on whatever that is, like doing breathing treatments through a nebulizer. Siblings also get worried about their brother or sister in the hospital. Remember, we talked about that way back in week one, actually, with preparing kids for procedures. You know, don't have the siblings at the bedside, especially for younger siblings. You're going to traumatize the younger sibling if they're watching their brother or sister get poked and prodded and that kind of stuff. So also get worried about their brother and sister if they don't know what's happening. You know, a lot of times the siblings don't get to come to the hospital, but their imaginations can run wild, have a lot of like concerns and questions about things that are happening outside of the healthcare setting. Helping give them that support. Sometimes we'll send home packets with parents of like, here's some extra information for your siblings at home to help them like see and learn and read about what's going on with their brother or sister that's sick in the hospital. General surgical procedures. Remember that psychological and physical prep beforehand. The parent's presence when it comes to surgical procedures depends on the procedure, but a lot of times we will let parents put on like the booties and the gown and everything and carry their child into the OR. And so that way they're with them till that last very kind of end, especially if we're doing sedation. You can stay with the child until the child's asleep, and then they'll leave and wait for the child to wake up. Preop sedation. What do you guys think is the best route, especially for younger kids? For your different routes of medication administration.
Would it be like inhaled nitrous oxide or something like that?
Yep. Yeah. Inhaled would be the best route because that way they can fall asleep. It's not painful. It's not scary as long as we've described it. And usually, honestly, what we'll do is we'll take something like, I've got a Coke flavored chapstick on my desk here. Something like the chapstick, and if you rub it on the inside of the face mask, it'll scent it. It'll scent the air. We let kids pick of like, oh, I've got cherry or grape. Which scent do you want? And then they can pick. They can breathe in that medication and they will fall asleep. And then we can do the painful procedures like the IV and the Foley and whatever else we need to do for that procedure. So that's our preferred route for pre-op sedation. Helps reduce that anxiety, helps, you know, with the amnesia so they don't really remember it, and helps sedate them for the rest of the procedure that we're doing. Post-op. Think about your post-op patient. What are some specific things that you're assessing and thinking about? Who do you have a bedside? So we've got parent at the bedside, right? We want the parent there. We don't usually pull them back immediately. We wait until the child's a little bit more awake. Kids are more likely to get post-anesthesia psychosis where they're like screaming and yelling and just like flailing afterwards until they're more awake. Basically it's like this dead stare. Like they'll be awake, but they're like vacant staring across the room, and you do that like, you know, hand wave in front of the face, and they're just like, they're gone. And you'll see it when they snap out of it. They're literally like, oh, and they'll focus on you at that point. My description with my daughter when she was in this like post anesthesia state, she went for her tonsillectomy. They pulled me back right away. I knew everybody that was working, and they were like, oh yeah, she's out, come on back. So as an experienced nurse, I knew what to expect. So I went in, and Aria was basically just like screaming and flailing. And the way I describe her movements is like an alligator catching prey. If you've ever seen one of those nature documentaries where alligators catch prey, they like clamp down with their jaws and then they roll, drown the animal. So basically she was like screaming with this dead stare and just like rolling in the bed. So like tubes and lines and drains and everything were all tangled up. And I basically just had to like bear hug her, and she would sit there and she'd be quiet, and then all of a sudden she'd be like, ah! And she'd scream out, and she'd just sit there and be quiet, and then all of a sudden she'd scream again. And it took her a little while to come out of that. It can be kind of traumatizing for parents to see. So we wait until they're through that a little bit more before we wake up the child to bring the parents in, so we don't traumatize the parent. We want the parents there as soon as possible. So what are important parts of your assessment? If you've got a post-operative patient, don't think about this any different than your adult patient. What are part of your assessments that you're looking at?
Well, I'd want to see their vitals,
Mhm.
and keep a close eye on those, and also like their surgical site as well. Make sure it's not bleeding or infected.
Absolutely, that surgical site, right? That CDI, clean, dry, and intact. Does the dressing look clean, dry, and intact? Does it look saturated? Inflamed, right? Drainage, anything like that. Your ABCs, yep, the respiratory status, and that goes along with those vital signs, frequent vital signs afterwards, and we'll slowly start to space them out. Are they breathing on their own? Do they need some respiratory support? That goes along with that airway, breathing, and circulation. Yep. Okay. What else? One more thing. So vital signs, airway, ABCs, your assessment site. Yep, your GIGU assessment. Yep. Have they peed? What is your intake and your output look like? Right, if they went to surgery, they're going to be NPO for a period beforehand. Then we have to wait until they're awake and alert, and they've got that gag reflex back, and they can take orals again. And sometimes that's in the post-op room, sometimes that's on the floor, and we have to wait a little bit longer. Like that Hirschsprung disorder, they have to wait longer for that post-operative period. But we want to make sure that we've assessed that intake and output. Output also includes things like bleeding in the emergent or in the OR. Was there any blood loss or fluid loss in the OR? So make sure you've got that good eyes and nose good. Kids with vomiting will just vomit. They're not very good, especially younger age ranges. They're not very good at recognizing, oh, I'm gonna puke, and like getting the bucket or making it to the bathroom in time. They will just puke. So yeah, having a bucket ready for them is important because they will just throw up everywhere. All right, good. Play activities as much as possible. And there's some good examples in your book on this one for post-operative things. Compliance issues, just general compliance stuff with peds patients. We've touched on a couple of these topics. Think about medications, like we talked about, blood pressure meds, that it can make your patient dizzy and have side effects that they just don't want to take it. So compliance can be from the patient from the patient themselves. It can also be from the parent, and the parent's behaviors can also cause compliance issues. Medication things, it can be because the medicine doesn't taste good, or the side effects or think that they don't want to take it. The diet and lifestyle stuff. Think about a teenager that just gets diagnosed with diabetes. We talked about that, restricting their behaviors when they just want to be independent, do things by themselves and express that independence. And now we're saying you have to make significant changes to your diet and your lifestyle. And they don't always want to. With a younger kid, with a toddler, it's because they're like stubborn and obstinate anyway. Treatment themselves can also cause some compliance issues. We talked about things like cystic fibrosis this quarter, and they have to do those breathing treatments 4 times a day. That can create challenges where they just don't want to do the treatment. So there's a lot of things that can lead to compliance issues. Assessing the compliance and assessing why, having challenges with whatever the treatment method is. I will be honest, with kids, it's one of the reasons why I like working with kids more than adults, is that they generally will listen more than adult patients will. And I think you guys saw a little bit of this in some of your clinicals. You'll see patients that come in with heart disease that have made no changes to their behaviors outside of the healthcare setting, right? They haven't stopped smoking, haven't stopped eating, McDonald's every day. Like they don't make some of those changes, but kids in general will listen to adults and make some behavior changes and compliance changes because an adult is telling them to, more likely than an adult will. but it also comes around with like challenges of why are they having challenges with compliance? Is it because the medicine tastes completely gross and the kid's just like, I can't, I'm not going to eat it. It tastes gross. So thinking about ways to fix that could be flavoring the medication or giving them a pill that they can swallow instead of a liquid that they have to swallow, so they're not having to taste it. So that's the treatment itself. Like sometimes we can change the treatment itself to a different method that gives us better compliance. Sometimes with the organizational stuff, it's things like the doctor's office is too far away from their house to make it after school. They just can't get there after school. Or maybe mom and dad have a job Monday through Friday, 8 to 5, and they just cannot get off work because their kid needs something, right? So we have things like, especially pediatricians' offices now have at least a day a week that they'll have evening hours. So they have like 5 to 8 o'clock hours that the parent can come in and be seen in those later office hours, or sometimes there's weekend office hours. Sometimes we do things like giving them a bus pass or, public transportation or a taxi voucher so that they can get to their appointment when they need to get to their appointment. So those are things that can help with organizational strategies. And then sometimes with the behavioral stuff, it depends on the age. If it's an infant or a toddler, the parent just has to say, we're going to do this because we have to do this. You can't tell me no, right? That like no answer is not acceptable at that age. With an adolescent, you have to talk to them a little bit more about why. Like, why is this important for your care? That teenager that has diabetes, why is this important for you to take care of? Remember, they're not always thinking in that future long tense. They can't necessarily think about like, oh, I may go blind some point. I may have some of these issues long term. Think about the here and now. Think about things that can happen. Like if you are not following your diet guidelines and taking your medications and you get sick, you can miss prom next week. Like think about those here and now and those kinds of things that impact them, as well as getting them into like peer support groups. That new diabetic teen, get them into a peer support group. That's really helpful for improving compliance with that age group. Now, we do sometimes see compliance issues that are neglect and abuse in our pediatric patients. In those cases, it is reportable as an abusive situation to your state agency. And there are different types of neglect that will happen because of this. It could be things like not providing the right meal or resources or clothing to the child, but it can also be things like medical neglect. I had a mom who had a child with cancer, and the patient had been discharged with oral chemotherapy, and mom didn't pick up the oral dosing when she came in for the next appointment. And so we asked her why, and we got reasons of like, oh, I don't have the money to get it, I didn't have transportation. And we're like, oh, great. Those are things that we can work with. So we got the medication, we got it while they were there and sent it home with her. Next visit comes around, med has still not been picked up and filled. And so we asked again, why? Because we met those other needs. And at that point, she was like, I don't think he needs it anymore. I'm not giving it. And had not been giving any of the other medication doses for it because she was like, he's better. He's cured. You said he's in remission. He's cured. I'm not going to keep giving him these meds. So that was a report to child services because it's something that can risk their life. It's a medical treatment that the child needed. So we had to report it to social services, and the kid was removed from the household because of a lot of other things that were going on with the family. But so sometimes we do see medical neglect and medical abuse that falls into those categories as well with compliance issues. But you have to assess, you have to look at why. Don't just jump to like parents not doing what they should be doing. What are some things that we can help improve? If we're still not seeing an improvement at that point, then maybe it's something that we have to consider of like, why is this not happening? Just like with adult patients, we have compliance issues. General hygiene stuff, especially thinking about your hospitalized patients. Skincare, bathing is one of the best times to do your full head to toe skin assessments. For kids, sometimes parents are doing the bathing or a CNA might be doing the bathing. Remember, you cannot delegate assessment to an assistant personnel, so you have to do the assessment. Yes, your CNAs know what pressure injuries look like in most cases, and they will come tell you. But you cannot rely on that, because if your patient gets a pressure injury that was not reported, it's ultimately your license. So make sure that you're following up with those assessments if you have somebody else assisting. Pressure injuries happen in kids. They're less likely to happen in our pediatric population in certain age ranges than adults, but they do happen. And differences between infants to adolescents with skin. When we are born, our skin is really thin. That epithelium hasn't developed. We have less subcu fat. We have less collagen. We have less support for our skin, and it's thinner. As we move through adolescence, so as we head into puberty and into your 20s, your skin is the best it is ever going to be. Your collagen is the highest. Your elastin is nice and flexible. So skin in those like adolescents, early 20-year-olds is less likely to get a pressure injury because of some of those protective mechanisms that we see. So infants are higher risk than adolescents, but any patient that has nutritional deficiencies, bony provenances, is bedbound, those are patients that are going to be high risk for pressure injury regardless of the situation. Common places that we see pressure ulcers for kids: occiput, ear, sacrum, scapula, kind of common areas that they're laying on, bony provenances, right? But we also see device-related pressure injuries in our pediatric populations, especially in the ICU setting. In critical care settings, you're more likely to see a device-related pressure injury than something like a sacrum or a scapula, because we turn patients frequently. We're pretty good at preventing those kinds of things, but we're not so great at preventing pressure injuries from devices, because sometimes they need them. This is a nasal intubation in this picture here. So this patient, this is a nasal intubation, and you can see what happened with this pressure injury here, that this caused some significant harm to this patient afterwards. So making sure that we're preventing those types of injuries is also really important, not just like those bony prominences in other areas. We also see shear injuries and dermal stripping in kids, more likely to happen with your younger patient, the infant, toddler. Their skin is thinner. Shear injuries are things like, you know, you go to turn them or you're pulling the sheet from underneath them, and that can shear the skin and cause an injury. Dermal stripping is literally what it sounds, stripping off the skin. And this happens more frequently, especially with infants, like an IV. If you have an IV in the hand and you're pulling off that tegaderm, you can literally peel their skin off with the tegaderm. It is horrifying when it happens, because I've accidentally done it before as well. Sometimes it just happens because their skin is so thin, it'll come off with the tape. Really careful removal of adhesive devices off of their skin, especially for younger age ranges. If you have adhesive remover, that also helps. At the minimum, even if you can't find adhesive remover, like an alcohol prep pack can help loosen up tape and get that off, so that you're not risking things like a dermal stripping from things like tape. Family education and home care, especially when it comes to things like training patients and making sure that preventing pressure injuries at home. And remember, week 1, we talked about those 3 goals: growth and development. Their oral care was one of them. So making sure that they're doing dental hygiene, whether they're in the hospital, and nutrition. Those 3 things that we talked about at the beginning. So feeding, nutrition, age appropriate guidelines for this, right? If it's an infant, bottle fed or breastfed, formula or breast milk, one of those choices, right? Once they hit 6 months, then they're going to start taking some table foods in. So age appropriate, but also think about their home norms. If the child is used to eating something that is not what we're providing in the hospital cafeteria system, then they may not be eating while they're in the hospital, and then that's not going to help them recover. You will see a really wide range of what this looks like across the board in the country. If you were working in a rural hospital, a very small rural hospital, you may not have any cafeteria services available to you. Many of the hospitals that I've worked in internationally around the world do not have cafeteria services, so families have to bring in the food for the child. Big places and big organizations like Children's, Denver Health, or UC Health, they have large cafeteria systems and they have meal services available for the kids. But like the Children's North Campus has a small inpatient unit. There's no cafeteria. Well, there was There was no cafeteria on site with the old facility. So you may not have cafeteria services available. And if you do, they may be really limited on what food choices they have available. So we do sometimes have to work with the families to help make sure that some of those home norms are being brought in, that we have those accessible for kids. Kids will eat what they're comfortable with. And that's really important to think about. Also remember things like those routines that we talked about. Keeping with those routines can help with eating behaviors and just care in the hospital, especially for younger kiddos. If they're not eating, some tips and tricks to get kids to eat. Make it fun, make a game out of it, right? So the concept of like a picnic, and I've literally laid out a blanket and put little things in and pretended that we're having a picnic before. Especially with your younger patients, the toddlers, the preschoolers, shapes, colors, sizes, different shapes, colors, and sizes can help. Literally cutting a sandwich into 4 pieces or like a heart shape, all of a sudden it's a new thing and they're like, oh yeah, that's cool, I'm gonna eat it. And they weren't eating it before, but all of a sudden they'll eat it because it's a heart shape. It's the exact same sandwich. They'll just eat it because it's a heart now. The thing about mixing it up and having different small things available throughout the day, especially for those younger age ranges, having snacks readily available for them throughout the day. Remember, kids can be picky eaters when they're younger, and just having those different choices. With parents in the hospital, if they're staying there, usually with breakfast, I tell them to order some snacks for throughout the day, because it can take a little while for the cafeteria service to deliver something. And when a toddler's hungry, they're hungry now. They're not going to tell you like, oh yeah, I think I'm kind of getting hungry. Go ahead and order the food because I'll be hungry in an hour. I'm not going to tell you that. You have to be prepared for those kinds of things. You also may not have the parents there to order things for kids. So you may be the nurse that's taking care of this kid and has to order food for this toddler that's in your care. I remember the first couple times that I had to do that and just had no idea. I was just like, what do you eat? And I've got a 2-year-old that's like, I don't know, looking at me like, I don't know what I eat. What do I eat? You have to order nutritious things, but think about a variety of different choices is helpful. And my one tip on that is cheese makes everything better. When all else fails, think about something with cheese. Cheese pizza, mac and cheese sticks, grilled cheese sandwiches. Like those are usually good choices most American children will eat, unless they're allergic to it. But those are some things that to try. The hydration that I've got at the bottom there with 3 exclamation marks. That is your priority, right? We talked about the GIGU system last week. Kids can become dehydrated faster and more significantly. So you have to keep up with the hydration when kids are sick. You know, a general cold, a viral illness, they've got the flu. It's okay if they go several days without eating. My daughter has not had anything to eat since Tuesday at lunchtime, basically. But it's not the concern at this point. Fluids are the concern, right? Because of that risk of dehydration. Think about creative ways to get fluids into kids as well, because sometimes they won't drink because of a strange setting, like being in the hospital. If they're used to a sippy cup, get the sippy cup. If they're used to a specific cup from home, get the cup from home. Other things that can help, games, making a game out of it. So I've got the concept of tea parties up there. And I've got the fancy picture up there, right, with the little girls having their nice little tea party. We don't have fancy teacups in the hospital setting, but what we do have are those little med cups. But what you can do is take those little med cups and set them up on the table and put, you know, apple juice and Gatorade and some water, different things in the cups, and make a game out of it. It's like, oh, let's try this, and like stick your pinky out and make a game out of it. Other things that work, especially with the school age group, is doing shooters. You don't have to tell them where you learned it, and a very different adult concept of doing shooters, like literally lining up the little cups and putting a little bit in each one and like making a game out of it of like, okay, let's see who can get through the end of the line fastest, and just taking it down. Get those fluids in. Those little bits at a time can really add up. So being consistent with it and helping figure out kind of what works best for kids, like what favorite fluid do they like at any age group, figuring that out. All right, fever management. I've talked about this concept a couple times. I said that we would touch on a little bit more detail this week. So Difference between hyperprexia and hyperthermia is important in terms of medical terminology. Hyperprexia is a fever that is related to an underlying inflammatory process. So that could be an infection of some sort somewhere in the body. It's causing, things like your prostaglandins to go up that will increase the body temperature. Your body's responding to that. That's hyperprexia. Hyperthermia is an elevated body temperature because of an abnormal set point. So think about the head injury that we talked about, or seizures. This could be medications that do this, strokes can do it. So anything that kind of damages the brain, so that set point is at a higher set point than it should be. Treating it is going to be different depending on whether it's hyperprexia versus hyperthermia. With hyperprexia, because it's an inflammatory process, using ibuprofen or acetaminophen can be effective at treating the elevated temperature. Now, the concepts with fevers with kids. Fevers in kids can be, okay, if you have a kid that has a cold and they have a fever and they are running around and they are playing and they are eating and they are drinking, it's okay for them to have a fever. Fevers mean that our immune system is responding to an underlying disease process and working to correct it. So when our immune systems are immature when we're younger, that 2-year-old that has a cold for the first time, they've never had COVID before, and they're exposed to it the first time, they may get a higher fever. But that's how their immune system's learning to fight it off. If they are comfortable and they are eating and they are drinking, they're not critically ill, the fever is not a bad thing. It means the body's doing what it needs to do, and you could leave the fever alone. However, if your patient is critically ill, your patient is dehydrated, your patient is having respiratory distress, those are things that we want to make sure we treat that fever, because it's going to put more workload on the body and cause more complications. Does that difference between those two kind of things make sense to everybody? If I could pick one general parent education topic to give to all parents in Denver, it would be fever management. Because I have parents that come into the emergency room that are freaking out because they're like, oh, my kid has 102-degree fever, and they're just really stressed. And they're like, oh, my kid's got a fever. And I pull them back. I'm like, okay, let's take a look. And the kid's happy, alert, sitting there. And sure enough, they've got 102-degree fever. And they've got cold. They've got a cold symptom, and they're sitting there with this 102-degree fever. They're okay at that point. But if you've got a post-operative patient with a fever, very different thing, right? So understanding the underlying cause of the fever and what's causing it, how to treat it, is really important when it comes to medical management with fevers, especially with critically ill children. The example with my daughter right now, right? She's homesick. She's had a fever off and on. So highest has been 101.5. That's actually considered a low-grade fever in kids. For us as adults, we get a fever of 101, 102. We're pretty sick by that point, because our immune system knows how to respond more effectively. We don't get higher fevers as easily. But a younger pediatric patient, the immune system is learning to respond to newer viruses and illnesses. They spike fevers higher. 104 is a high fever in a peds patient. 101, low-grade fever. So there's also a difference in terms of how high the fever goes for kids. But because she is considered unstable at the moment, because she's got dehydration, she has been taking minimal fluids in, I can't let that fever linger in her, because that's going to cause an increased risk for dehydration. Her body is having to work harder to fight that fever, as well as everything else that's going on, right? So her fever needs to be treated. But if she was awake and alert and talking and drinking and eating and doing all those things, and she had a fever, I would let it go. So it depends on the situation. Seizures is also a situation. Febrile seizures is something that children can get, usually under the age of 5. If they have febrile seizures and they get a fever, then we do want to treat the fever, because we don't want them to have a seizure. So that would also be an exception with a kid that gets fevers, treating if they have febrile seizures. All right, the other concept with hyperthermia, if it's due to a stroke or seizures or metabolism or aspirin or other drugs, it can't be treated with medications. because there's nothing that medication is going to work against, right? Like ibuprofen, blocking those prostaglandins. There's nothing to be done with hyperthermia with a stroke patient. It's because of that abnormal set point. We have to use cooling methods. Cooling methods only for hyperthermia for this patient. So that would be like ice packs, or we have these cooling blankets called bear huggers that you can make cold or hot. Those can be used for cooling methods for this patient. But the fever, the hyperprexia, you can use both. You can use cooling methods and ibuprofen and acetaminophen for that patient. Hyperthermia, just cooling methods are going to be effective. So knowing why your patient has a fever is important. We talked about that with the cerebral dysfunction. An example of a kid that I had that came in with medication drug overdose. He had a body temperature of 106, and it was from an MDMA ecstasy overdose. And so she came in with a 106-degree body temperature, did not survive. She went into multi-organ failure from that elevated body temperature. But the only thing that we were using to reduce her temperature were those cooling methods, because medications are not effective at bringing that body temperature down from something like that. All right, I put a link to the Children's Hospital website on fevers because it's got some great information about Motrin and Tylenol dosing, when and how to treat fevers, and like when you see the doctor and not. It's a really helpful resource for parents related to this. Kids get fevers all the time, but just how to manage that is important to think about. My OD patient last week had a temp of like 102. And that one's more manageable. Did that patient survive?
No, unfortunately not.
That's a bummer. Sorry.
She was like 24. Yeah.
Okay. What drug?
Fentanyl.
Yep, it's unfortunate. And we see it in peds patients all the time too. You're less likely to see things like drugs and alcohol overdoses in peds patients, but more so with adolescents we do. Oh, all right. Let's take a break there. And then we'll go into safety and medications. So it's 12:27, come back at 12:37. Conversations with friends yesterday about this topic at the hospital. I was talking with my doc yesterday about it at the hospital. Okay, let's talk about safety of a different kind. So ID bands with our peds patients. So with adults, we talk about, okay, you go in, you ask them their name, their date of birth, and you verify with their ID band. You can't ask an infant that. So how do we make sure that we're doing safe medication administration and care with infants and toddlers and younger kids that can't tell us all of that information?
Do you get the parents to verify their two patient identifiers?
Yep, ask the parents. Ask the parents. Tell me, your child's name and date of birth. Now, there are cases where we don't have parents at the bedside. This does happen a lot, especially in the ICUs, when kids are there for a long time, sometimes on the floors. You just may not have a parent at the bedside to ID the patient. One of the important steps that we make sure that we're doing when we put ID bands on with children is that we have the parents verify that bracelet before it gets put on. So as the nurse, in a future care scenario, if you know that was double checked at the beginning when it was put on, then that you have the correct bracelet on that patient to verify when you go in to give a medication. So you're double checking your MAR to the bracelet if you don't have that person that can verbalize with younger kids like infants and toddlers. Environmental factors to think about in the hospital setting, electrical socket covers. We talk about those kinds of safety things at home. We also need to worry about those kinds of things in the hospital setting. So covering socket covers for younger kids, like the toddlers, small objects, that choking hazard, kids under 3, any small object can be a choking hazard. So even if those like little bits and pieces from IVs and other medical things that we do, we have to make sure that they are not at the bedside. Furniture also needs to be at the lowest setting, and it needs to be the appropriate furniture choice for the patient developmentally. So think about the difference between like a crib and a bed. And I've got some pictures here in a second that we're going to go over the differences with that furniture for the different developmental stages. Activity supervision, toys, especially for younger children under 3, so infants and toddlers. That choking hazard is a big thing. Lots of toddlers play with Hot Wheels cars at home. I am not going to be responsible for giving a toy to a young child that is a choking hazard. On the Hot Wheel box, it says not suitable for kids under 3 because it has small choking parts. So if you go into a room and you have a child playing with a toy that is not age appropriate, education is important. And if you have a parent that's like, they play with Hot Wheels cars at home all the time, this is his like favorite thing to play with, let them play with the Hot Wheels car, but make sure that you document that education was given about the safety related to those toys. So just make sure the toy is age appropriate, safety wise for them. Preventing falls. All PEDS patients are fall risk, but there are patients that have increased fall risk on top of that, right? You know, think about the fact that a toddler is just learning to walk anyway. They fall all the time just because they're learning to walk. But there are things that increase that risk, like a patient that's on narcotics or maybe has a neurologic disorder that causes dizziness. There are things that can increase that fall risk. So we have higher fall risk from the already there fall risk. You won't usually see fall risk bracelets like you will in adults, you know, when they put the ID bracelet on, they also have like fall risk bracelets. We don't use those in PEDS because we assume all PEDS patients are fall risk, but keeping extra careful care when you have patients that have an increased fall risk is important to think about. Sleep safety is also really important. This kind of goes along with the furniture in the room. So sleep safety, we talked about the ABCs of safe sleep. So alone on their back in a crib is something that we have to keep in mind in the hospital setting as well. Infants cannot co-sleep while they're in the hospital setting. That is not something that we will allow because it is not listed as a safety factor as the safest way to keep kids in the hospital. So they have to be independently sleeping in a crib or a big bed if they're an older child. So thinking about what that looks like. So this is an open crib. These are used only until kids are rolling over. And this is one that, you know, the picture here is demonstrating the safety if you're stepping away from the bedside. So the crib rails have to be up if you're stepping away from the bedside. Even if you think that this is a baby that is not rolling over yet, and you're like, oh, they're not going to roll off the changing table, they will somehow wiggle themselves off, and you don't want to be responsible for that fall. So things to keep in mind, especially if you're newer to working with infants, it can be very easy to like absent-mindedly step away from the crib or the bedside. If you keep in the practice of putting your hand on them while you're doing things, then if you turn around and that hand's there, you can keep them safely in place, or you'll realize if they're starting to move, right? The other thing is if you're turning around, just get in the habit of putting the crib rail up. Just put the crib rail up if you're stepping away from the bed at all. Even if you're just like stepping across the room to grab something, put the crib rail up. Parents also need this information because we don't want your child to fall while they're in the healthcare setting. And that includes falling from surfaces like crib. So we want to make sure the parents are also practicing those habits of putting the crib rails up. These are other types of cribs as well that we use. This is a different type of an open crib. So this white one here where my mouse is moving, this one has 4 rails that go down. So these ones are nice, especially when kids have oxygen needs or we have to suction. Getting access to their feet is easy because you've got 4 rails here. This is also still considered an open crib. So once they're rolling over and sitting up, they should be moved to a closed crib. This picture here shows a closed crib. Not every facility you work in will have easy access to these, but larger pediatric facilities will. This is a closed crib. It has 8 rails on it. So there are 4 rails on the bottom here. You can see how this one, where my mouse is moving right here, this one is up. These other ones here that are down will raise up to that point. So they'll all come up to meet at the same height. You have 4 rails there at the same height. Now think about toddlers. Toddlers like to climb, they like to walk, they like to practice things in the middle of the night, and they can climb over surfaces in some cases. So a toddler can easily climb over that crib rail and fall out of the crib. So because of that fall risk, we have closed cribs for these kiddos. So this has these top rails here, and you can see at the head of the bed here, this plastic one here that closes down. So all 4 of the top rails close down and meet to where that bottom rail is, and there's usually a gap about like this big between the top and the bottom rail. So this is not considered a restraining method. It is an age-appropriate safety tool to keep that toddler safe, to keep that infant or toddler safe. This is different than something like the posy bed. If you've seen posy beds or remember learning about them in class, a posy bed with that like kind of cage thing that goes over a bed, that is a restraining tool. That has to have an order for it. But for this is an age-appropriate safety tool that we use for kids that are under usually 4 years of age. And then once they hit about 4, depending on the facility you're working in, there's some variability with that, but usually about 4 is when you can start putting them into the big beds, and then they can sit in the big beds. They still need to be sleeping independently. They should not be co-sleeping with any age range. They still need to sleep independently in their crib or their bed. A safety tip on this one, parents also need to know this. For using these cribs, I had an 18-month-old one time, a little girl who mom had been given the instructions on how to use the crib, and she did not practice them, and so she ended up having the bottom rails all closed, so like the bottom rails were all raised here, but the top ones were open. And so she went to the bathroom, and she had her daughter, who was 18 months, flipped out because mom left the room. And so she was upset, and she was trying to like get to mom, and she climbed out of the crib. And you can see these are really tall heights here. So she fell out of the bed and cracked her head. She got a giant goose egg. Fortunately, she hit the front of her forehead, which is the strongest part of their heads, and didn't have any significant harm. But I had to do a QSRS, I had to do a safety report, I had to call the doctor immediately. We had to do a scan because of this head injury and this risk for severe harm on this kid. If mom had just closed the crib rails, we would not have had to do that. So making sure parents understand that importance of closing those rails is important too. All right, transporting kiddos. If you're inside the unit, parents can be walked or patients can be walked or carried. If you're literally like going across the hallway to like the treatment room, you can carry that little baby. But if you're walking outside of the unit and you trip and fall, that child can fall. Some harm can come to that child. So you do not want to transport a child just carrying them, yourself or the parents carrying them. There's a risk for injury there. So if we have an infant, it can be easy to put the parent in a wheelchair, have the parent sit in a wheelchair, and then the parent can hold the child, the infant, in their lap, and then you can push the parent in the wheelchair. That's one way to do it. Other ways would include things like the stretcher or the gurney, or using the crib or the wagon, the bed or the isolate, just depending on what that age appropriate bed would be for that patient you can use for transportation. Kids love wagon rides, and I've got this picture up here with this kid in the wagon. There's a picture of my daughter in that respiratory chapter in the wagon. Kids love wagon rides. They're great for kids. We use them a lot to transport through the hospital. You can put like all their medical stuff and their pump and everything in there. Those are helpful. In the peds setting, you'll see those a lot in the peds setting. For the critically ill child, you do not want to carry them at all. Make sure that they are in their age appropriate bed, so either a crib, an isolate, or a bed, and that you have your safety equipment. That monitor and your oxygen, your safety equipment is transported with you. Even if you think your patient's fairly stable and you're going to x-ray, have your safety equipment with you just in case something happened. You have to have that safety equipment with you for critically ill kiddos. All right, restraining methods for kids. First thing to ask yourself is there a need? Do we have to hold this kiddo down? Sometimes there's not. Sometimes we can do it a different way. A therapeutic hold should be something that you should consider first if you can. And I've got a picture of that in the next slide, of thinking about what that therapeutic hold is. And either a nurse could do it, a CNA, somebody that your assistant can do it, or a family member can do it. And it's really helpful to have the parents with that assistive device. Mummy or swaddle restraints, and I've got a picture of that in the next slide as well. Jacket restraints, like a straight jacket, we do use sometimes more, I've never seen it outside of the mental health setting, honestly. And then limb and elbow restraints. Remember we talked about those last week, this elbow restraint here, keeping that elbow from bending so that they can't pull at things. Different examples. So this is a mummy restraint or a swaddle restraint, just like we swaddle a baby up. This can be helpful, especially for temporary holds. So if you're starting an IV for this baby, if I was starting an IV, let's say I'm using this arm here that's sticking out, I would wrap the other arm up, keep this arm out, and then kind of wrap the blanket underneath them. So everything else is restrained, but I've got the arm exposed. For the purpose of doing something like an IV, if it's a temporary hold for a procedure, you do not have to have an order for it. So if it's just a temporary hold for procedure, you don't have to have an order. If it's something like the elbow restraint, remember those have to have medical restraint orders for them. This bottom one is called a pigostag. It's a funny name. It's for radiology, to help position for radiology. Honestly, most of the time we just have the parents help position, but this is one that's helpful, especially for more independent scans. This is a papoose board. She is smiling way too much to be in a papoose board, but these have nice Velcro straps. Usually they're hard on the bottom and they have Velcro straps that close to help restrain. Honestly, a blanket works just as well. And I tell kids that I'm like pulling them up like a little burrito, and it's just going to be for a short amount of time. Before we, do the procedure, whatever else that it is that we have to do for them. Now the family hold with the therapeutic hold. This is a picture of a therapeutic hold on this slide here. So there's multiple things going on in this picture that I'm going to point out. We've got dad holding the child in this therapeutic hold. It's a hug hold basically, and you can do it with either the child facing the parent, like this picture, or away from the parent, where the kid's like sitting in their lap and the kid's facing out, and they're still going to do that like upper body bear hug basically. So dad is holding this child in position and keeping that body kind of restrained. Their hand that's out here is not able to grab at the nurses that are starting the IV. We're able to access the arm that we need to start the IV or do the procedure on. And then the legs, while not restrained, can move easily, but they're also not going to cause harm to nurses that are starting this IV. And then don't forget, we've got child life therapy over here doing some pulls and some distraction techniques for this child. Yesterday when we were at Children's, my kiddo was watching a movie on the TV. And child life therapy came in and asked her if she wanted any coloring books or a stuffy to love on and hang on to. I'm just helping provide that comfort. Those are big tools and resources that child life therapy can provide in the pediatric setting. So that's a therapeutic hold for this picture there. Helpful positions for venipunctures, for giving IM injections, or any other sort of like access to the body limbs. Just think about having the other parts of the body restrained and not easily accessible to grab or hit or punch the nurse. Especially for younger kids, that is necessary to just hold them down to have to do those procedures sometimes. Therapeutic hold is great for IM injections because usually we have pretty good access to the deltoid in an older kid or that vastus lateralis in the thigh for a younger kiddo. So those are helpful positions. And then for the lumbar punctures for peds patients, this lateral sideline position is the best position. A school-age adolescent, you can do that sitting on the side of the bed position. They can usually hold still for that, but the lateral side leg is the better position for preschool and under. Urine collection. So remember we talked about the urine catheters last week. In some cases we can do clean catches on kids, and usually this is cases if we're like testing a BUN creatinine. It doesn't have to be a sterile collection, so we can do clean catches. And for babies, it's going to be a bag that we use. So this is a little bag. It sticks to the skin. So it's one of the reasons why they easily get contaminated, because they just like stick to the skin, and like anything that's on there can end up in the bag in your specimen. Boys, much easier to get it to stick than girls. But this is an example with a little girl with this bag on. So if you're doing a clean catch, this would be the preferred method. Another way that you can do a clean catch with an infant is to take cotton balls and to put the cotton balls into the diaper and like put the diaper on them. And then when they pee, those cotton balls will soak up the urine. So you take the cotton balls out, get a big 60 cc syringe. If you pull out the plunger, you can put the cotton balls into the 60 cc syringe and then put the plunger in and squish out pee. That's another way to get a clean catch on an infant. We do also have urine collection containers for 24-hour collections in infants and younger kids that have like a little, these bags. There's some that have these little bags to them that have a little tube that go to like a bigger collection bag. But we also have, you know, the bottles that we would just do like the cotton ball method and squish it into the bigger collection container as needed. Specimen collection with other things for stool. You can't like squeeze it out of a diaper. So if they're diapered, you have to either line the diaper with something so that it keeps it from absorbing in, like some plastic saran wrap actually works really well for this, so that it doesn't soak up into the diaper, and then you can get a specimen that way. Or the collection hat in the toilet works for an older kid. For blood, the difference between your finger and your heel stick. The heel stick is your preferred method for 6 months and under. So under 6 months of age, it's going to be the heel stick. Once they hit about 6 months of age, then you can start to do the finger stick. But honestly, even infants have tiny, tiny little fingers. You can do a heel stick in an older infant too. It's just that under 6 months of age, do not use the fingers. And it's the same method that you would do for a finger stick. It's going to be the side of the heel, just like the picture here is showing, just like we use the side of the finger pad. It's the side of the heel. You're going to use the alcohol prep pad to prep it. You know, if you're doing like a glucose check, you wipe away that first drop, and then you get your sample. So the same thing is true for the heel collection. It is helpful sometimes to have warmth beforehand. So like having their little feet warm so they're not cold helps. If you guys haven't seen these, hopefully if you've done your OB rotation, you saw some of this with those like heel sticks. We have these little products in the hospital setting. They're little heel warmers. They're like, you know, the little hand warmers that you can buy at the store for yourself in the wintertime. You basically crack them open and they get warm. So you can put this around their little heel before you do it. That'll help bring that blood to the skin, and it'll help get your collection a little bit more easily with those. A no-no for heels that you may see done by like older school nurses that should not be doing it this way would be something like a warmed washcloth with like hot water on it. Because it is not temperature regulated, it should not be used to warm up the skin. Other older methods that we used to do would be things like putting like a wet washcloth in the microwave to get it warm or hot, and then like wrapping it up with a Chux pad. We also are not allowed to do that anymore. Kids have been harmed by using those older methods, and so we just should not be using them. They're not appropriate to use anymore. Sputum and nasal washings, gastric washings. With little kids, they can't just like hack up a loogie. So a lot of times with some of these types of collections, you have to hold them down and get a suction catheter to get a specimen for them. You know, with the nasal swabs, you have to hold them down, get that good nasal collection for nasal swabs as well. All right, and then peds med. So we're going to talk about just some like med administration kind of routes and different things. This is a different color, but it's in the same chapter 20 still. We're still talking about the same chapter 20. And these are things that we've touched on already, but we're going to just like reinforce some of that medication administration and just talk about a couple different routes. Remember, with your med administration, drug dosage is usually weight-based dosing for a pediatric patient. There are some reasons that we use body surface area for drug dosing, more so specifically with like your chemotherapy medication. Those are going to be body surface area sometimes. Make sure that you're double checking your medication, your ID band has been checked appropriately, whether that's independent checked by the nurse or with the parent or the child, depending on the child's age. And then preparation for the child and the family needs to be considered. When I'm giving medications to younger kids, I have to give them education about what the med is and why I'm giving it on their developmental level. But then I also want the parents to know more information about what the medication is and why we're giving it and what the side effects are. So it's pretty common that you'll have to give for education. It's like with procedures, you have to do it different ways for different age groups. Tell you one of the most common questions that kids ask is, what does it taste like? Literally just what does it taste like? And I've tasted pretty much every med out there just so that I know what it tastes like. So that you can kind of prep them a little bit, like, oh, this one's minty, that one's cherry, that one's strawberry, whatever it is. So you can give them information. Remember, the dosing is smaller dosing with your peds patient. They have different body surface areas. Remember that it's smaller, but that larger proportion, that percentage is larger. Their immune systems and the maturity of their other systems, like their kidneys and the liver, do not metabolize and process medications the same way that adults do. That is why we have different medication ranges for patients. In your drug books, you will find for some medications, it'll just say peds and adult. And that's it. There's just like the 2 dosing, and it's the weight base versus your adult dosing. But for some medications that are a little bit more specific and more harmful or more risk of harm, you'll find like neonate dosing, infant dosing, a child between this age to this age, adolescent dosing, adult dosing. And there's more specifics that we have because their body systems do not function the same way in every age range. So those ranges are going to be different. The other thing to keep in mind with med administration with our pediatric patients is that usually as us as nurses, we are the last line of defense against making sure that we are giving the right medication to this patient. There are multiple checks and balances in that process, right? The doctor orders a medication, that medication is verified by pharmacy tech or whoever it is making the medication, that medication is sent to the floor. The nurse on the floor is checking that medication, double checking it as needed, and then giving it, right? We are ultimately that last line that gives that medication to that patient. So if we mess up, it's ultimately our like last step. We could ultimately be at fault if we give that medication. And kids, younger kids, can't speak up and say, hey, that doesn't look like the right med, or that looks like it's too much for me, or this tastes weird or different than it did yesterday. This pill is a different color than it was yesterday. Adult patients can, not every time, but they can. Peds patients, we are really kind of that last safety check. So the reason that I really stress dosage and making sure that your medication administration is really accurate with your pediatric patients, because it has to be, it just has to be. Make sure that you follow your rights of medication administration, thinking about why are we giving this drug? Is it the right reason? Have you checked your allergies, your assessment, think about your renal hepatic function, risk for side effects. The right weight has been recorded for your patient, that it's recent and accurate. Your highs and lows, is it within the safe ranges for your patient? You're doing your, I know I have 6 rights on there. I think we're up to 8. You're doing all your right medication, right time, right dose, right route, right patient, right reason. All of your rights of medication administration need to be checked. And then ultimately, if any discrepancies, question it. Do not be afraid to question the provider. There may be a reason why that medication is outside of the range from your drug book, but they may have accidentally ordered the wrong range, and pharmacy may have accidentally checked it off. It does happen. It happens honestly all the time that those checks don't always work. So make sure you just speak up and ask about it. You don't know until you ask. Don't be afraid to question it. All right, different routes and just differences that we're going to talk about with our pediatric patients. So oral medication, you talked about this with adults, things to think about with med administration with your peds patient. So I'm going to give you an example of this. I'm going to pull out a syringe. Okay, so we've got an oral syringe, right? And if you're drawing up your med, whatever it is, if you have to crush it, dilute it in a small amount as possible, flavor it as needed. And infants, toddlers may not cooperate. Even preschoolers sometimes have trouble with med administration. Usually by school age, kids will take meds appropriately for you without like eating it too much. But the toddlers especially will fight. And I've got a picture up here with a toddler because this is a challenging age where they just like maybe won't hold still, they won't swallow the medication. And I have lots of parents that come in for, let's say the kid got an ear infection and the parent comes in and like, I just can't get them to take their medication. They won't take it for me. And my answer is usually, Well, they have to take it for you. They need the medication. You are the adult. Let's talk about ways to be successful with this. Getting their kid to take the medication, right? Sometimes we just have to hold them down and do it. So here's some tips on this, on how to do this with the younger kiddos. If you're in the hospital setting, you have help, it's helpful to have somebody else that will hold the patient down while you're administering it. If you're by yourself, it's going to be a little bit more challenging. So I show parents both ways to do this. If you have the helper, help make sure they're holding the head in place and they've got that head in their head held still so you can give them that. If they're by themselves, the picture here shows one way of doing it, so that you've got that like hug hold, so the kid's there, the mom's like holding the other arm, this arm is like out of the way, right? Can't grab at it because they'll try to grab the syringe out of your hand. Your hug hold is there, other hand's restrained. Now sometimes what they'll do even in that position is the like head flailing, where they're just like they're like heads back and forth, and it's really hard to give the med while they're moving their head like that. So I show parents the head like hold technique, where literally like the head is in the arm and your head locks the kid, not at the neck, at the head part. You're like holding their head in place so that you can get the med. So you've got them in that like headlock position. You've got the head there. You've got the mouth there. You take your syringe, you get it in the mouth. And if you get it in the cheek between the teeth, they can't close their mouth and spit because they will spit sometimes. So if you get it back here between the teeth, they can't clamp their mouth closed because they'll do that too. And you've got it between the teeth. And then slow administration. So a little bit, let them like gurgle it. They'll swallow it a little bit at a time, take your time with it. Don't squirt the whole amount in all at once. Give them a little bit of time. The other thing that's helpful for spitters, because some kids will like put it in their mouth and then they'll spit it out at you, is to pucker their lips like this and then across shut. They can't spit. So if you've got it in there and you're like puckering the lips at the same time, they can't spit it out. You're giving it slowly into the back of their mouth. Parents think you might be drowning them because they sound like and they're gurgling on it, but it will go in. What was I gonna say about that? Just be slow with it. Don't pour the whole amount in. Rich for choking on it. I was going to say something, now I forgot. Sometimes it's helpful for the parent to give the medication. Sometimes they're scared of us as the nurses, so it is okay to like give the parent the medication and say, you know, do you want to give it, or ask them if they want help with it in certain cases, especially in the hospital setting, because sometimes they're just scared of us. Flavoring, and then teaching kids to swallow pills at a young age. Kids can start swallowing whole pills at 2. So a 2-year-old can learn to swallow a pill. Just have to be shown how to do it. Usually by preschool age ranges, kids can swallow pills effectively. Literally practicing, and I tell parents to practice with like little mini M&Ms, because if they don't get it down, it's, you know, soft chocolate or it'll melt. So those are helpful for kids like practicing getting pills down, because then they don't have to swallow the medication. It liquid meds, some of them just are so disgusting. The taste of them, like liquid clindamycin, is just, does not matter how much you flavor it with, is gross. So teaching kids to swallow pills is helpful. We also have chewable ones nowadays for some meds too. All right, IM administration. So remember with small kids, that vastus lateralis on the leg, like she's showing there, is the best place. For older kids, usually we say 2 and up, we can start using the deltoid. For smaller kids, you can still use the vastus lateralis older than 2. Like my daughter is so tiny, her deltoid muscle is still tiny. Her vastus lateralis was used until she was like 5, just because she was so little. So up till at least 2, vastus lateralis is preferred, and then you can go up from there. Max amount of an IM injection is an important part for giving IM medications. Does anybody remember how much your max administration amount should be for one IM injection in an adult? Like how many milliliters can it be, or should it be?
I think like 2 mLs.
Could be a little
maybe
bit
3.
more than that. You can do 3. So 3 is max for an adult. So your adolescent, 3. Your school age child, 3. So for peds patients, you can do the 3 mLs, but for infants specifically, you cannot do that large of an IM injection. 3 mLs is a lot of medication in their tiny little muscles. So an IM injection in an infant up until 2 years of age is 1 ml is your max administration amount. There's some variance with this depending on the facility, but for an infant, 1 ml should be the max administration amount. So that means if you have a medication that comes out to 1.2 milliliters, you're giving 2 injections. If it's over 1 ml, you have to give 2 injections. It can be split evenly. It could be 1 ml and 0.2. I usually just split them evenly so that it's an equal amount to be absorbed by the muscle. Give 1 in each thigh for that split up. Once they hit about 2 to 3, then you can go up to 2 mLs. And then once they hit school age, you can hit that 3 mLs. So 1, 2, 3 mLs for that max administration amount for those IM injections. And the needle size, I don't go into specifics on the needle size. It really depends on the type of IM injection that you're giving and the size of your patient. There's not like specifics, like a 2-year-old needs this size, but the bigger the patient, the bigger the needle can be. Other types of IV devices. So we've talked a little bit about like the central catheters for peds patients. Your peripheral lock versus heparin lock, the big difference between those two, right? Saline is used for peripheral IV, like in your hand or your AC. Heparin lock would be used for central line. So that could be something like the Broviac or a Metaport or a PICC line. You would heparin lock those so that they do not clot. The amount of heparin that is used for those heparin locks is going to depend on the size of the catheter and the age of your patient. In adult patients, you know, it comes in like a 10 ml syringe for heparin. If you grab a heparin lock out of the Pyxis or Omnicell, and it's okay for most adults to use that whole heparin lock. But for a peds patient, like an infant, if you pushed a whole 10 ml heparin lock syringe into them, you're causing a heparin bolus. So for little kids, it's going to be a much smaller amount. You don't need to know the specifics on that at this point, but just remember that like concept of being cautious with heparin administration, whether it's for a heparin lock or, you know, like an IV infusion of heparin for something. Different types of central lines. I've got different examples up here for them. You'll see all kinds of different ones for peds patients. In younger peds patients, you may only see a single lumen. In an older patient, you may have a double or triple lumen, so bigger line, bigger access. In infants, sometimes it can be really hard to have multiple IVs all at once. Sometimes they just have one line. It makes it hard for med administration. I've got an example with a video for you guys to look at in a website with a kid with a Broviac and just like more discussion. It's got really great information about a kid that has more like chronic medical needs called She Got Guts. And I think it's a great like teaching. It's a mom who like put together all this information about her child's medical needs. And I think it's a great example of just like some of those things like a Broviac and a G-tube and some other stuff that goes into that. These are other examples here. So this one is a Broviac. This one right here with the little guy at the top here. This is a double lumen. It is a central line. It's a tunneled central line. And this is during a dressing change. He should be wearing a face mask. These are older pictures. We didn't always used to make them wear face masks, so this is an older picture. But if after the dressing change is done, he'll have that sterile occlusive dressing over it, the tegaderm that's over it to block that site. Risk for infection, right, for that. This one is a Metaport that has been accessed. You have to use special needles to access Metaports, Huber needles for that. I know you guys don't get experience with that in nursing school, but you'll see these once you get out of school, and you'll have to, you know, learn how to practice and putting the needle in for these. The Metaports, there's several different types of Metaports that you'll find for kids, and usually you'll find them over on the left chest somewhere. Like usually they're up in this region, but sometimes they're like on the side of the body. I've even had some over here on the right side. They're usually up here kind of in the chest, and basically you kind of palpate of where that port is. You'll feel either a round or triangle shape under the skin, like positioning, like feel where it is, and then your needle's going to go into that port. And that's what this looks like in the skin here. Is there's this port part is is sewed in underneath the skin, basically. So those are kind of different types of central lines that you'll see with kids. Or either of those power ports. The picture here is not. Power ports are used in kids. You won't necessarily see them in younger kids just because the basic difference between like a regular port and a power port is that the power port can be given at high flow rates. So there's differences like how fast you can administer medications with them. The power ports are usually a triangle shape. So when you're palpating it, it's a triangle underneath the skin versus the circle shape for the regular ports. That helps us like differentiate between the two. It'll also be documented in the chart when it was placed of what type of port it is and what size it is.
Cool, thank you.
Yeah, there's other like details about like there's different sizes of needles that you have to use to access it, like how deep you go in with the skin. So there's a lot more of like, once you get into like doing them, there's a lot more practice. You'll find those if you go into oncology, you'll work with those a lot. So you'll get used to working with those in oncology and sometimes in the ER or ICU as well. All right, we've talked about eyes and nose in class, so this one should just be a refresher. Make sure that your fluids are being measured, intake, output. If they are diapered, we can weigh those diapers. 1 gram of diaper weight is 1 milliliter of output, whether that's urine or like combined urine stool. So it's a 1-to-1 ratio for that, for weight to weighing. And don't forget, you have to subtract the dry diaper weight. Easiest way to do that is take the same size of that diaper, put it on the scale, zero out your scale, take off the dry diaper and put your wet one on. Or you can just subtract the overall weight. Intake, we've talked about maintenance fluids versus dehydration, and just other things to think about with NPO status with kids. The NPO amount of time before a procedure is going to depend on the patient's intake type, whether it's an infant or an adult patient or an adolescent patient. One of the things that we have to remind parents about sometimes is making sure that they do not feed their child, even if the child's fussy and uncomfortable and hungry, like knowing what the important reason is behind the NPO status before a procedure. Also not eating in front of little kids, because if the child, 2-year-old that's hungry, doesn't understand why they can't eat if the parents are eating in front of them. We tell parents to, like, you know, leave the room, go to the cafeteria, go somewhere else if they have to eat while the child's NPO, so they're not doing it in front of the kiddo. Other things with your peripheral IVs, so different things with securing and protecting the IVs. Removing them is basically the same, but things to think about with kids is that like that removing of the tape can be scary for little kids, even though we know it's not like a needle. They just associate it with things like the needle. Letting them help with that process. Think about things like that tape adhesive, using like an adhesive remover so it doesn't hurt as much when you're pulling off the tape. Complications from the IVs. Infiltrations can happen faster and more significantly with little kids. They have IVs that we'll put in that are much smaller than adults. Like your big old 18 gauge IV manage a faster flow rate. The vein is less likely to occlude than like a tiny little 24 gauge with a little tiny infant vein. Infiltrations and extravasations have to be looked for. You have to assess that IV every hour. Every hour you're looking at that site and catching those signs, because kids may not tell you that it hurts. They can have giant infiltrations. They haven't said a single word about it. You have to be careful with assessing for it. And we talked about that with like chemo meds. You know, if it infiltrates, stop med, call the doctor, call your provider, and then go through the steps of like, is it something we have to worry about an antidote with? Can we pull the IV out? What do we need to do about replacing it? In terms of securing it, so there's different things to secure arm boards with kids. The picture here shows a couple different things to keep in mind. So this one has a little IV house on it. So it just helps protect the IV site so that it doesn't get bumped or pulled out. I'll be honest, most of the time in the healthcare setting, in the hospital, we just put a washcloth over it. We just like wrap it in a washcloth. You have to take the washcloth off every hour to assess it, but it helps protect it and it kind of keeps it out of sight, out of mind, so that the kiddo's not pulling at it or, you know, bumping it, knocking it out. And it helps like distract them from it if it's covered up and it's out of sight. Now, one of the things that we do use with peds with IVs is arm boards. This helps protect the IV site so that they're not doing things like bending the hand. Like an infant, you can't say you have to keep your arm straight. We have to put arm boards on them. So this is one type of arm board. Sometimes it's just like this cloth one. This is another type. I've got my hand here. This is a hand one. This is a hand one that goes on like this. And then you've got the tape that goes around the fingers here, and then you've got one that goes around the hand here, and then another one that goes around the forearm here. And these are stretchy so that they don't occlude, they're not tight against the skin. The one thing that we used to use is Coban. This is a no-no and should not be used. This can cause harm, and it causes occlusion. And loss of circulation. So that's why I've got a big old X here, is that do not use Coban or something like just tape that goes circumferentially all the way around the extremity, because that can tourniquet the arm. If you're using tape, you only want to tape it to the point where it goes partially around the extremity, not all the way around the extremity, because that will occlude. This is an exception because it's been tested, because it's got those stretchy bands on it. This is an exception to doing something like the circumferential all the way around the arm. And then older kids, they can tolerate with just having the IV in place, like you'll see with an adult, of just like taping it down and leaving it out and open. But usually for preschoolers and under, we're going to put an arm board on and we're going to cover it. It is also an age appropriate safety device. It is not a medical restraint, even for like the wrist one here or the AC one where they've got taped, well, basically tape it under their arm like this so that they can't bend the AC. It's a safety device. It's not a medical restraint, so you don't have to have an order for it. Other types of IVs, scalp IVs are used in babies sometimes. Babies usually have bald heads. They can have really hard access on the extremities. So it can be easy to see their little scalp veins. And we use those IVs just like we would any other peripheral IV. Your needle does need to be inserted toward the heart. So if you're putting one in a scalp vein here, make sure the needle is pointed down. Your catheter is pointed down towards the heart. You don't want to point it up this way. I have seen people do it wrong. I've just seen nurses do it wrong. I've also seen hand IVs with the needle pointed like this. So make sure it's always pointed towards the heart. IO needles are also used in kids. The most common site for your IO needle for a pediatric patient of any age is going to be this proximal tibia here. So it's that lower extremity, that proximal tibia in the lower extremity. And those are used more in emergency situations for rapid infusions, med administration, code situations where we can't get an IV in place. Parenteral IV. You guys have seen the pumps over in the sim lab? Been able to play with them? I don't know if everybody's finished their sims yet. Everybody got a chance to kind of look at them a little bit. Yeah. Okay, good. So with your peds patients, a lot of your medications are going to be smaller doses. And so especially for secondary medications, we use these pumps. This is like the most common pump you'll see across the board. If it's not like a big primary bag that we're using, are these syringe pumps. And we use syringe pumps for multiple different reasons. We can use it for medication administration. We can use it for continuous infusions. We'll even give NG tube feeds with a syringe pump for kids, for babies, especially that have really small amounts of NG tube feeds. Different supplies, different connectors, but the pumps can be used for a lot of different reasons. We program weight-based too, so like a dopamine drip, we can do micrograms per kilo, per dose, or per minute. So those are really common that you'll see at peds across the board. And there's a couple different types of syringe pumps. This is the more common one that you'll see, this Metafusion one. But there's a couple different ones that you'll see used for peds. That is a handy one for peds patients. Fluid restriction. So remember we talked about fluid administration with peds patients, that maintenance fluid calculation. So if you have a patient that's on fluid restrictions, let's say we have a kid that's in kidney failure, that we talked about last week, and they are on strict I's and O's, and they need less fluid than their maintenance fluid because of that kidney failure. You would calculate what their weight-based appropriate fluid should be, and then multiply it by whatever that restriction is. So if they're on 2/3 maintenance, figure out what the maintenance dose would be, multiply it by that 2/3 to get your appropriate milliliter per hour for your patient. The same thing would be the opposite if we had a patient that was like your patient with sickle cell anemia that needs 1.5 times. You figure out what their normal maintenance would be, multiply that by 1.5 to figure out what the maintenance would be for that increase. Does that make sense on that for fluid restrictions or increased amounts for kids? Awesome. Okay, eye drops and ear drops. Well, one thing with eye drops, same technique for peds patients that you've talked about with adults, right? You need to pull down. Excuse me. And get it into the pocket. Oh no. Okay. Kids can be challenging with this, especially infants and toddlers, where they're like blinking and they're moving their head and they're flailing around with this. So some tips on this. If you have your hand on their forehead and your hand is resting on their forehead, your hand is going to move with their head. So even if they're like flailing and doing this, your hand will go with their head instead of trying to do this like back and forth thing here. The other thing that can be helpful for eye drops too, with like preschool and school age kiddos, is if you have them with their eyes closed like this and you put the med into the little pocket here where the lacrimal duct is and have them open up and blink, then it'll go into the eyes. And sometimes that's less scary for kids than having them like holding it open and dropping it into their eyes. Those are some techniques for helping with that. General infection control stuff, the same things apply. Teaching parents, not touching the tip to the eye, keeping it closed. They shouldn't share medications, good hand washing afterwards. Nasal atomizers are also a medication that we use. This is a nasal atomizer. So it has a lot of benefits, and two more common reasons that you'll see this used in peds is pain meds or sedative meds. And especially in the ER, we use these a lot. Quick, easy med administration. So if you're giving something like fentanyl, basically what this does is it aerosolizes the med. I don't know if you can see it on the video. It like squirts it out in like a fine mist. That is something that they can inhale in their nose because we have all those little capillaries in our nose, and then we don't have to start an IV. It's not painful for them. It's on that one, and kind of med administration for that one, it shouldn't be more than 1 milliliter per side. That's like really max. If I'm giving more than 1 milliliter, it really shouldn't be an intranasal administration. Usually if I'm giving 1 ml, I'll do like half in this nostril and half in this nostril. If they're old enough to sniff at the same time, have them like your breath while you're doing it. Also have something for them to drink afterwards because they'll taste it in the back of their throat, and it can be like, those meds can be really bitter. Have something like a tissue and something to drink afterwards if they are NPO. NG tubes, OG tubes. No difference with this with peds patients versus adults for measurements. So I've got a picture on the next slide, this one, right? Remember, you go into the tragus, nose to tragus to the xiphoid process. For this, the biggest difference for insertion is that, especially for babies and younger kids, they can't like swallow or do those techniques at the same time. They also can't easily sit up, so a lot of times you're doing it in that flat position for insertion for these. Same thing is true for this for adults. Put it in, you're looking for color changes, you're looking for coughing, make sure that they're not having any distress, you didn't get it in the lungs at the same time. And then you have to check pH and x-ray for a new placement for these. The old method of just auscultation should not be used, even though you may still see somebody do it that way. It is not the book answer, it is not the correct way to check and verify placement. It should be pH and x-ray to verify placement for a new NG tube. Show you the one picture here. This one here, these are a couple of securement devices that we use. Taping it across the teeth. We don't use that little like chevron across the nose. Their noses are too small with babies. They're also like more oily, so it just won't stick. So usually with infants, you're taping it to the cheek. And think about out of sight, out of mind, so that it's like sometimes out of the way here and like tucked back this way so that it's not dangling in their face so they can pull at it and pull it out. We're out of time. I don't know, it's 1:30 already. We talked about a lot of these techniques for absorption of feeds, the positioning, the right-sided. That's an older G-tube. That was the Mickey button. We talked about that one last week. TPN and lipids, really just making sure you're measuring peds appropriate, ped specific. Rectal meds, those are a couple position differences. And same thing is true for kids for this. Just make sure you hold their butt cheeks together for giving a rectal med administration for this one. That's just like, they can't like hold it in like we tell an adult. You just have to hold their butt cheeks closed for a couple minutes afterwards. And then oxygen, different methods for oxygen administration. There's different sizes, peds, infant peds and adults. That is a oxygen hood. Monitoring oxygen therapy. That all should be, that's pretty much the same for peds and adults. Your chest physiotherapy, we talked about that with CF patients, with that chest physiotherapy. Remember we talked about that one. And then the airway sizes. So just a couple differences, smaller size. And our pediatric patients, you will use uncuffed because their airways are smaller. They're softer. We don't use the big cuffed ones like we do with adult patients. So with peds patients, usually you'll just see those uncuffed. There's no balloon at the end to inflate for the trachs, but the same thing is true for trachs, for care, for suctioning, just smaller size, smaller catheter for those ones. That's the biggest difference. Just some examples with babies. Yeah. I'll do the practice questions at the beginning of class next week. We'll see how you guys do. You retain this information next week. Have a good holiday weekend this weekend, guys.
Thank you, you too.
Yeah. Thank you.